on guys, welcome back to my channel. In this video I'll be going back on Dr. Prepper and we'll be going through how I would use it if I was still in medical school to show you guys how to study for your exams. I recommend starting this whether you're in your third year, fourth year, fifth year. I think normally around third year is when your clinical year starts and you start going on placements more, and you have a lot less lectures. A lot of your time is now spent on studying for your exams yourself, so be it using resources like SBA question banks, PassMed, QuesMed, PassTest, things like that, doing some placements, and trying your best to be in placements and see as much things as you can and get CBD signed off, mini kexes, then doing some OSCE revision. But oftentimes, especially when doing SBA questions, you do reach a point where you just start memorizing sort of like the patterns or the keywords they say to like trigger what answer to select or what answer to pick, and then translating that over into OSCEs where like you're speaking real time, you have to come up with your differentials real time and your investigations real time and piecing together which bits and pieces of your history is relevant. I often find that quite difficult, which is why I created Dr. Prepper. At first it was just like a web app, but now I've made it a website. I did it during the period between when I graduated from medical school and started my first job as a doctor here in the UK. So let's go and get started now. So we should be recording on my screen. This is the Dr. Prepper app. This is my page. So this is what you'd see on the home page. You can read this if you want. This is just some information that I got from students, some feedback from medical students. And actually no, this is my statement here. So Dr. Charles Mazarika, that's me. This is what I think. This is why I created it. Just my own little blurb. Then here's some feedback from what students are staying in St. George's, and also what a medical registrar was doing as well. So yeah, this is it. There's different places to navigate. You can view your progress as well as you go through different cases. So if we click in now, we can see your progress. So let's say my overall score is 48%. I wasn't doing this properly. I just clicked 0 and 1 on some cases just to test it. So I could do much better than that, trust me. Then obviously when you go to your progress tracking, you can see with the score that you get in your differentials, then your investigations, then your management, because you're able to score each section, and then your score comes up over here. Then you can go through case performance history. Let's say this cardiology case I did, which was a patient that was feeling faint after exercise. Their average score for this specialty, so from all the cardiology cases, is 60%. The case score is 44%. Then you can see the individual breakdowns for each score. 67% for differentials, 33 for investigations, 33 for management. So we can see here that this case, this website, can really allow you to see which case or which area of your history do you need to work on. For most people, you should be able to go on placements, to get feedback from CTF or senior doctors, or from even F1s and F2s, and also from your OSCE feedback from friends to how on how to take a good history, on how to and correctly go through your presented complaints, your history of the presented complaints, family history, past medical history, social history, drug history, and as well as that, ICE, ideas, concerns, expectations. You should be able to work on that yourselves. It's just that last 3 minutes. So let's say you have a 10-minute station. The 7 minutes is where you do your information gathering and collecting. Then that last 3 minutes, when your examiner asks you, okay, what do you think is going on? What is your summary? What is your differentials? What is your investigations? What is your management? That is what this is meant to fill, to bridge this. This isn't meant to replace either. It's just meant to be a tool for you to sort of piece it all together. All the knowledge that you've acquired from your preclinical years, all the SBA knowledge as well, all the knowledge that you get from OSCEs and from doing placements, to merge them together and allow you to work on cases yourself, just bash through cases, and then of course when you get good at your differentials, your investigations, your management, when you go back to OSCE practice, back to placements, you'll be better able to say everything clearly, because of course medicine is a real life topic. You won't be getting SBAs on your day-to-day job as a doctor, but of course you still need to pass the exams, you still need to do well in your SBAs and to do well in your OSCE practices. For any of you guys that signed up for the rest of this year, I'll be making your account pro, so you get access to 500 cases. So I think it's over 500. Initially it was free. There's 50 free cases, but if you do just sign up now, I'm just making everyone's thing free. So please just leave your email there, just sign up, and I will do my best to help you. So let's say these are all the cases that we have here that we can go through. Let's say we want to go through ear, nose, and throat. Here's all the cases that we have here. So let's say this patient here is a gradual hearing loss in 1 year. So we can open it up and see the case. let's read through the case and let's work through it so you see exactly what to do. A 60-year-old man comes in with gradual worsening hearing loss in his left ear over the past eight months. He also reports occasional tinnitus but no vertigo, ear discharge. He works as an accountant and has no history of noise exposure or previous ear surgery. Examination reveals normal external ear and tympanic membrane. He's worried this might be something serious like a tumor. Gradual left-sided hearing loss over 8 months. He has occasional tinnitus. There's no vertigo, no noise exposure, no previous ear surgery, no ear pain or discharge, no other neuro symptoms. He's concerned about the possibility of a tumor. And there's normal external ear and tympanic membrane. On Weber's test, it lateralizes to right ear. Rhesus is negative on the left. The cranial nerve is normal. There's no visible ear canal obstruction. What is going on, guys? Okay, what is going on here in this case? You know, we have the history here, which is pretty much what you would get, you know, from like your history of the processor complaints. And here's a quick summary of the history, the key relevant bits, and then we have here some key signs that were found on examination. So whether you've done a 10-minute exam or a 10-minute station or a 15-minute station where you have to take a history or take a history plus a combined exam, this is the information that you would get that is relevant and is high yield and should be able to help you to analyze and to figure out what to do next, or what your differentials are, or your investigations, or your management. Also similar to what you would get on like SBAs as well, but here's just a bit more information. Once you've seen this, we now can go down to our scoring guide. So over here we have 0 is equal to relevant or no suggestions, 1 is very limited or mostly incorrect suggestions, 2 is some correct ideas but it's missing key points, 3 is strong, complete or near perfect suggestions. Okay, and now if some of these things or these answers aren't exactly right, then please let me know as well so I can improve it and improve upon the answers, but most of them should be okay. So let's say we want to put in our top differentials. So let me just read it myself because I was even wondering like what's going on. So he has gradual left-sided hearing loss over 8 months, which is worrying because it's gradual, it's slowly worsening. But there's no noise exposure, there's no trauma, no neuro symptoms. It's where there could be and something wrong with him. So Weber's test lateralizes to his right ear, so maybe it should be some form of conducive hearing loss. Works as an accountant, no noise exposure. So I'm thinking it could be something as simple like earwax, so cerumen impaction. Another thing as well that we could have is like since Rinne's is negative on the left ear but Weber's lateralizes to right ear, it could also be some form of tumor, which would be the main thing that I'd want to rule out. But it doesn't seem to be compressing any cranial nerves, and there's no visible ear canal obstruction. So let me see, it's been a long time since I've done this, but let's see if this works. Cerumen impaction, I'm not sure if this is the correct way to write it. What is right here? Let me see, there could be a mass in his right ear, I'll just call it that. Or what is it called, like is it vestibular schwannoma? That's what's coming into my head right now. Schwannoma. And a third differential, because he has tinnitus as well. Ooh, this is a good one. There's no signs of infection. I don't think it's anything, you know, to do with like labyrinthitis or, you know, vestibular like neuritis. There's not enough signs to say that, so let's just leave it with 2 for now. So okay, yeah, the main one is vestibular schwannoma or acoustic neuroma, which is also had as my second in no particular order, or sudden onset sensorineural hearing loss, which is less likely because it wasn't sudden onset. So again, you could put this down, but I was going to, because like it wasn't sudden onset, so it wouldn't really make sense to put sudden onset sensorineural hearing loss. But this could be an option if you were doing your SBAs. And otitis media with effusion, which is conducive hearing loss, but there's no visible infusion. So otitis media with effusion or cerumen impaction, these are good solid answers. So in this case I have what, maybe 1, but I do think 2 may be good, but let's say for the sake of it, I give the score of 1. Investigations that I would like to do to rule out schwannoma, I'm thinking in particular order. You probably want to do like an MRI, right? You want to refer to your senior. If you wanted to rule out sudden onset sensorineural hearing loss, you know, if you're worried it's like a stroke, you may want to do like a CT head and go down that pathway, but I'm more leaning towards a vestibular schwannoma, so I'm probably going to put that one down. And the third line test is just refer into hospital, refer to your senior, but I don't know if that would be an option because that's more leading towards management. There's nothing else I really want to do here. Let's see what the answers are. MRI of the internal auditory meatus with gadolinium contrast, tympanometry to rule out conducive concepts. Tympanometry is good, and brainstem auditory evokes and potentials if MRI is unavailable, and ENT neuro exam for cranial neuroscience. So they already gave me the cranial nerve test, but I guess doing a full-on ENT test, maybe using the otoscope. Yes, let's say otoscope would be good, but obviously tympanometry is also a good sign as well, because I was worried that it was some form of conducive hearing loss. So in this, I no need for CTS. In this case, we're doing quite bad, but let's say 1 as well. Management, let me see, refer to secondary care services. So this could be something like the hospital. Then I also want him, because he needs to go for a scan. In the meantime, manage anything that needs managing conservatively. So pain relief, safety net him if it's worsening, or if this if it happens on his other ear, any changes in sensation on his face or weakness, face drooping, to come back in. I won't write all of that, but you guys get the gist. So safety nets. So managed conservative, refer to secondary care services. I'd also counsel him on what this means for him and what a vestibular schwannoma is, and the potential of having surgery on his ears. There's no previous surgeries, but he needs to be seen by ENT. Yeah, so refer to secondary care services. So ENT, refer for assessments, observation versus surgery or stereotactic radiosurgery, which depends on the size of the symptoms, audiology input for hearing aids, long-term surveillance of watch and wait chosen. So this would be a 1 as well. So then after we've done all of this, we can go to high yield information, and we can see progressive unilateral sensory neural hearing loss as a red flag for acoustic neuroma. Early MRI is essential for diagnosis. Teaching should cover the importance of differentials conducive versus sensory neural cases, and when to refer urgently, and management options including surgical removal, stereotactic radiotherapy observation. UKMLA often tests on the significance on asymmetrical hearing loss and when to escalate. Okay, so after we've done all that, we can also write our comments for what we think is going on here. Maybe say like interesting case. Let me see. Maybe give more info on the exam. Like, let's say that was your feedback. Give more info on the examination findings. You could say something like that, and then you could click post your comments. And then when you finish, press save all of your answers, and this will save your answers in that as in the progress section. So let's say we say leave the page, we go to the progress section, we go to where was it, ENT, and then we can just wait for this to load. Okay, I may have clicked off too fast, but you'd come back here and your answers would be here and available for you to see. So I hope this guys makes sense. I hope this makes sense. If you do want to support, also on the tracker, you can see your highest score here, which is 56%, and the case completion tracker, which shows how many cases you need to finish all 500. So here is 14%, so there's still a lot more to do. And if we were to go into our specialties, we can see that there's so many cases. Like, let's say for surgery, for example, I have over 100 cases there in surgery. So you can just keep scrolling down and down and down. Different areas of surgery, if this is something that you're interested in. Okay, so I hope this makes sense. I hope this is useful for you guys. If you do enjoy this, please let me know. This is honestly my pride and joy right now. This is what I've been working on. Thank God I was able to really work on this. I have a TikTok as well where I post quite frequently. I'm posting like every day, giving you guys tips on examinations and like tests and UKMLA and things like that. It's Dr.Prepper _1. So definitely check out this webpage. I'm doing a lot here. I also have an Instagram, but I'm mainly posting on TikTok at the moment. I'm also posting, going through cases on this website as well. But yeah, please feel free to sign up and let me know what you guys think. And yeah, I'll see you guys in the next video. See you later.